muscle re-education.
Yes.
All right, so what do you want to do?
Can you repeat the case? I missed some part.
Can I repeat what?
The case.
Can I repeat the case? He's a 24-year-old, and he's had a femoral fracture. And as a result of the femoral fracture, he was in a long leg cast. Long leg cast was removed, and he's got an extensor lag of 30 degrees. What do you want to do?
Probably muscle re-education. And
You want to do muscle re-education. So how about you, Cindy, and Isaiah, just take two minutes till I get this set up to discuss this. So discuss it and tell me all the parameters. So the three of you can provide me that information, or provide us that information. Okay?
With the alcohol.
Go Vince Carter, dude.
Dude, greatest dunk of all.
Of all time. That's
Dunk
what I
contest of
Oh
all
yeah.
time.
That whole dunk contest. Like everyone in that.
oh yeah.
Vince Carter still has a little bit of a start on this one. Yeah, he played for the Hawks. At least I'm pretty sure he played for the Hawks.
Like 45.
Is what?
So, what would be those?
I don't know. You tell me, Steve.
Well,
No, milliseconds is, microseconds is for, micro-
250 to 350 for lower extremity. Like you still want 30 bucks.
That's a DC count.
Thank you.
Yay, nay.
Anybody speak to Melissa? Yeah, I have her on. Okay. I am just fine and dandy. How are you?
yeah, they can't really tolerate
I am
it.
getting ready for your exam next Wednesday. I think I'm going to give you some review questions. I gave you some review modality questions to use for clinical, for your scenarios, for your practicals. I think I'm also going to give you some hard questions to figure out. Not hard.
Wait, say that one more time. Like not passing
They're
conversation.
not hard. It's because you keep talking, so shut up.
I was talking about the question.
I think I'm going to give you some questions. Think about pulse width, pulse rate.
So,
different things. No, I think maybe I'll give it to you today, later in class. Yeah. I'll finish up what I've got to finish. The exam's next Wednesday, the written. And Professor D'Onofrio said he would be available, because if I give the practical on Monday, I think it's too soon.
Thank you.
Yes, thank God.
So
That's
I'll
amazing.
give the practical the following Monday, all right? So you have this time just to review the written stuff, and then you should be able to pick out, multiple choice question. And then the following Monday will be the practical exam. Okay, and then we'll start gait, and we'll have a month to do gait, manual muscle testing, and goniometry. So it's a lot to do in a little time. But, I'm not gonna, I just want to definitely get through gait. The other stuff we could begin, and you can finish it if we need to when we do therapeutic exercise, but at least we'll get
Should
through
probably
that.
start studying like tomorrow.
It's also come to my attention that it's difficult to hear back there. I'm sorry that it is, but to make it even better as far as people hearing, when we ask questions or when we discuss something, we don't want everybody to be talking to one another, because that would even further make it more difficult for people back there to hear. Okay, so, excuse me?
Noise impedance.
Thanks, Steve.
Impedance? Or is it attenuation?
Is it
if we're going to be, if I'm gonna ask a question and everybody starts to discuss the answer to the question with each other, then the people back there might not be able to hear. So, just be mindful that it's difficult to hear when you're in the back of the room.
Like that?
But you guys can hear me okay?
Very nice.
Rich, you're always back there.
Yes.
And Juan, you can hear?
6% deep, baby.
Yeah? And you guys hear?
I can't.
You guys can hear over there? Okay. Shut up.
You must have sonic hearing.
Steve, I can hear your stomach growling.
All right, so what did you come up with?
Because all hearing is sonic.
Isaiah, Cindy, and Brian, somebody stand up and be heard. I don't care who it is. Brian, I picked on you first, so tell us what you think about that scenario.
Alright, so we're gonna wanna do a muscle re-education to try to promote more knee extension.
Okay,
And, we're gonna do Russian protocol.
okay.
So we're gonna keep it between 35 and 50 hertz,
What are you gonna keep what between 35 and 50 hertz?
the frequency.
Okay, why?
So, 'cause anything above, like anything pushing closer.
Why did you pick 35 to 50?
Huh?
Why did you pick 30?
Because it promotes a tetany response.
You want technique.
Yeah,
Okay,
so, we're not trying to fatigue the muscle.
okay.
So we probably set the ramp time like 10 seconds on.
That's too long.
To what?
That's too long.
Too long, not the ramp, the off time. So it'd be like 10-second contraction.
What's that known as?
Huh?
What's that known as?
That is,
It's an on-off time, right? Or it's a duty cycle?
yeah,
Okay.
pulseration.
So on-off time of what?
On-off time of 10 to 50. So 10 seconds on.
10 to 50?
10 to 30.
10 to 30. Shut up, you two. All right, 10 to 30, go ahead.
Alright, so we're gonna have the patient work with the machine. So
What about your pulse duration?
pulseration?
Pulse duration, what do you want your pulse duration?
Our pulse duration, probably
Take it one.
got me on that one. Pulse duration is how long, like, it's gonna be on.
So how long?
So, but we already said
So how long?
10 seconds.
Oh,
Or
10 seconds.
What's this one on, 30
10
off?
seconds on, 30 seconds off.
Seconds?
Or 10,
You're talking about duty cycle now. I'm
okay.
talking about pulse, the current duration.
Oh,
Frequency of 35 to 50, what's the duration? Or the width, if you use that word. Pulse width, pulse duration. Cindy, what are you writing down?
I'm thinking it'll be high duration because 35 to 50 is.
High duration. So what does that mean?
The lower extremity.
As far as times, what are we talking about? What kind of seconds? Are we talking about a second? Are we talking about a millisecond? Are we talking about a
Alright,
microsecond?
It's gonna be milliseconds, it's a
Are we
lower-
talking about a millisecond with an innervated muscle?
Microsecond.
Microsecond. So how many? For the lower extremity?
250 to 350.
250 to 350. Okay. Is that set in the machine? Probably.
Yes.
It's probably already set. Yeah. However, I'm still gonna ask you, you know that. So, okay. What's the time on, time off?
10 seconds on, 30 seconds off.
Okay, what are you gonna tell the patient to do?
Work with the machine, so maybe have them do an exercise like a quad
Good.
set while the,
All right,
while the,
sit down. Chris, Spencer. What's the difference between a volitional muscle contraction, which means that the patient's gonna do it themselves, and an electrical stimulation contraction? Is it the same? Yeah, one's voluntary and one's involuntary. One's with the machine. What is the difference as far as what's happening inside the tissue? Anything? Is it the same? Is it different?
It's different in the sense that, I guess that when it's voluntary, you're recruiting specific muscle fibers, whereas involuntary for the stim is gonna be a small one.
Okay, so you're saying it's selective
Yeah.
to muscle fiber recruitment? Is that what
Yeah.
you're saying?
Yeah.
Okay, good. If you're saying that, you're correct. Anybody expand on that?
Volitional muscle contraction recruits motor units as they're needed, and so it doesn't recruit all of the muscle contraction at once, whereas with the stim, it's the contraction is all at once. You recruit all of the motor units at once, full contraction.
Okay. How about any selective, any specific muscle fibers?
Voluntary is type 1.
Well, for
Type
Easton,
one is
it's
Voluntary is type,
They're voluntary is type 1 fibers.
type,
Voluntary is
don't we recruit type 2 fibers with voluntary also?
No, I mean you can.
Sure you do.
You can.
Fast
Later on in
fibers.
deeper contraction,
With
yeah.
Easton, it's type 2 fibers first,
It's
which also fatigue first.
Correct. So with a volitional contraction, we do have slow and fast twitch fiber recruitment, except we recruit slow twitch fibers first, and they're gradual. The contraction is more smooth. When we do electric stimulation, we that machine selectively recruits type 2 fibers, which are fast twitch fibers, which fatigue quicker. Yes.
Does this have anything to do with like synonymous with like glycolytic, fast glycolytic or fast like oxidative muscle?
Yes.
Muscle
Yes.
Okay.
Yes. Okay, so electrode placement, we started to talk about the other thing I'd mentioned was an FES. And I don't think I have it here, but an FES is a functional electrical stimulator. It operates on the same principle as anything else we've talked about as far as electrical stimulation and as far as muscle contraction. If we want a muscle contraction, we need a longer pulse duration, right? And that really is activating the opiate release, the endogenous opiates we have in our brain, and we want a motor response. So if we wanted to do it for pain, that's what we would do. But if we wanted a muscle contraction for muscle re-education, we would also have to have a long pulse duration, right? And something that actually gave us tetany, which is like 35 to 50 hertz. So if we had a functional electrical stimulator, portable unit, which we do in class, and you guys can try it, you would need to place it directly on the muscles you want to stimulate, right? That's no surprise. And it's used a lot for things like gait. So we could put it, if somebody had drop foot, then we would need to put it on the anterior tibialis, right? And we would have to time it. So we would have to use this on a patient and think about when he's striking his heel, when he's putting his foot flat, and when he's going the toe off. So we would have to time this to turn on every time we needed dorsiflexion. And when we start talking about gait next week, we'll talk about the fact that there are concentric and eccentric contractions, and eccentric is always slowing something down, right? So if I were to strike the heel of my leg, of my foot on the ground, in order for my foot not to collapse,
Eccentric.
I would need an eccentric control of the dorsiflexors, right? And I would need a concentric control of those same muscles during the swing phase of gait, right? So every muscle, whether it be eccentric or a muscle that's an extensor or a flexor, has to eccentrically and concentrically control. Because as I'm swinging my leg forward, what's happening? My hip flexors are working, but we're also working to control the fact that I don't do this when I walk. The eccentric control of the glutes and the hamstrings. They're slowing the limb down, okay? So if we had to do functional electrical stimulator, we would use a stimulator, we'd place it on the patient, we'd either attach it to the patient and have it go on for those seconds when he would require dorsiflexion and then go off. Okay, so it's a little bit different and it takes a little bit more time to set up. However, has anybody ever seen one used? No? Okay, but you can, it's good to substitute for an orthotic, like somebody doesn't have an orthotic. It's good to try to teach the person in muscle re-education, but it's a functional activity, right? Because you could sit there till the cows are home, come home, and do this and this and this, and with your patient in supine, how do you know that's helping them when they have to walk? So we might need to look at something more functional. Yes?
Can you use this continuously on a patient, or do you only use it for like functional training? Like, so if they're, like, throughout their day, they're experiencing like a drop, like, can you just, like, program this, clip it to their belt, and let them go all day with it?
You can?
And FES is rated at 10, it's only like biphasic or Russian, and 10
You know, I would have to look into that, the manufacturer for what current is used. I'm sure it is, I'm not sure what current is used for that. I'm really not. I would have to look that up. But it has to be something that is strong enough to elicit that motor response. Yeah, so it'd probably be something like a biphasic current in, in those portable units, and they're battery operated. But there's, it's amazing what's happening with, obviously, with computers and everything else. It gets so advanced. If you went into a gait lab, they could probably set something up on you after they watched you and after they analyzed you via computer and see, okay, it's this time, it's that time, it's that time. We'll just set it up, place it on you, and you go. That technology has advanced that far. But what we can do at our level is a lot less than what can be done if you're in a gait lab. However, it's also very important because we need to functionally try to get that person to use that limb. So whether they have an orthotic on or not, our goal is to get that, to restore that motion, right? So, okay? Yes. All right, so what do we know? Christopher, put your hand down. Jade. I'll get you in a minute. Jade, tell me what you know about pain. And what to use for pain. What to use for pain. What do you know about pain? If we were to put electric stim on someone, we talked very quickly the other day about the little TENS units and the type of settings that we could have for TENS units, right? We talked about an acute problem, and we said it helps for as long as the stimulus is on, and we could set it on somebody and the person could have it on all day. We would certainly probably have to modulate that current because they would probably be turning it up all day long, right? Because they would accommodate, they would adapt and accommodate. So what do we know about these little TENS units? Do you remember anything we talked about last time as far as what parameters we would set for what? So for an acute pain problem, what parameters would we select? She's really whispering. Can you hear? I can't hear anything. Is the mouth moving? I can't even see because the mask is on. He can't. If he can't hear, then I know it's not me because he hears everything. So what do you want to say about that, Jay? Do you want to tell me anything about acute pain versus chronic pain?
If it's an acute, it's high frequency, low duration,
High frequency, low duration for what?
or acute.
For acute pain, yeah. And that works on that theory of the gait theory, right? Okay. What do we do for chronic pain?
Chronic pain would be low frequency, high duration.
Low frequency, high duration. Good. And what will we do for some to create analgesia? That only lasts for 15 minutes. So to stimulate C fiber firing.
Thanks.
Anybody remember? Chris?
That would also be low frequency and like a really high duration.
Reef intensity to be high frequency, high duration.
Oh, so that's different than noxious.
Yes.
That's what I'm
All right,
saying.
so we're thinking of burst, stem, acupuncture stem, conventional setting, acupuncture setting, burst setting, and brief intense. Okay. Yes, your question?
So on the machine I was playing around with yesterday, it had VMS. I was asking the PT if she ever uses Russian for muscle rehab, and she says instead of that she uses VMS, which is variable muscle stimulator. Are those very similar? Are those?
And is that
VMS
what
and-
she said to you? It's a variable muscle stimulant?
No, she just called it VMS. I looked it up. It's very-
EMS?
VMS.
EMS. VMS?
VMS.
V as in V? Victor?
As in Valentine.
Valentine's.
Oh, shit.
VMS burst.
VMS first. Okay, so it's a different stimulant. What's its frequency? That's what you should ask.
She didn't know.
Is it a heating frequency? Well, you should have asked her.
No, I asked her. She didn't know.
Okay, so you should have said, is there a manual? Right?
Think
Because
the
the
project's
manual
in.
will probably explain what it is. It's probably another kind of stimulator. There's so many out there.
She said she uses that instead of Russian. Like when people would use Russian, she uses that.
What?
They don't have Russian on these machines. There's no like option
Well,
with it.
well, she uses it for muscle re-education?
Yes.
Okay, so it's got to probably have a frequency that's associated, that's similar to Russian. But it's something you should, does it come out in bursts per second?
Yeah.
Okay, so it's just another name, it's another manufacturer, it's probably the same, has the same.
Very similar parameters.
Yeah, but there's a ton of stuff out there. There's all new machines.
All these modes.
Yeah. Yes, Steve.
Also, I thought I heard you say that brief intense and noxious are different.
Brief intense is noxious, yes.
Oh, okay, it is noxious.
Yes.
Okay.
Yes, and it only lasts for about 15 minutes. Okay, so when we have a TENS unit, a portable TENS unit, and we want to, let's say somebody's got like, wrist problem. Maybe they have carpal tunnel. Can we, so the carpal tunnel involves what?
Tendons and other,
What are you saying there, Brian, with the Y?
I didn't say anything.
Exactly. That's why I'm asking. What's carpal tunnel involve?
The tendons and the nerves that run through the tunnel.
The tendons that run through the tunnel, yes. What are the tendons that run through the tunnel?
Flexor.
By the way, this is the way the
Okay.
practical's gonna be. Okay, so I'm just giving you a preview.
And median nerve.
Anybody?
The flexor digitorum profundus and superficialis in the median nerve.
Tendons of the girdle.
Yeah.
Okay. What else? What nerve?
The median nerve.
Okay, where's the median nerve come from?
Two, five, six, seven?
5, 6, 7.
Okay, you have to remember the brachial plexus,
Yeah, so I'm doing.
and you have to remember the chords. All right, and then the
5, 6, 7,
terminal
5, 6, 7.
branches.
I'm pretty sure it's all of them. There's more.
So remember the lateral cord and the medial cord, the lateral cord and medial cord come together and end as the median nerve, yes?
Yep.
So
Okay. So, if I wanted to do a spinal cord segment to surround the spinal cord, where the nerves are coming out, right? Where would I put the pads? At what level?
C6,
Yeah.
C7.
C5, C6, 7, you could take your choice because the median nerve is coming from a lot of those areas. Right, so I could put 2 electrodes here, I could put 2 electrodes here, I could surround the point of pain, I could use acupuncture points. Remember I said the one acupuncture point was right here, it's a Hoku point, I could place it there. I could place it at the trigger points, I could place it at the paraspinally, but not on the spine itself.
Median nerve does come from all of them, right?
Yes.
Okay.
Okay, so, I think we're okay. I think we're okay. How about, did edema, and we said that we did edema with, we could do edema with stim, we could do it with high volt, we could have an on-off time. If we wanted to do it for wound healing, we want to do E-stim for wound healing, what do we use?
DC.
Well, remember I said it's a high volt pulse current, right? It's a high volt pulse current. And we have a polarity associated with that. So that's high voltage. High voltage is anything greater than 500 volts. Now, do we want to choose a negative or a positive polarity? If it's
Pain is
inflamed
positive.
or if it's
Edema is
infected,
negative.
we use a negative polarity.
Edema is
If
negative.
it's not, we use a positive polarity. If it's edema,
Negative.
usually negative, right. And also your book states, and it's common, if you're not getting results after a few times with a positive polarity, if you're choosing a positive polarity, switch to negative and then see what happens. Yes?
So it's positive polarity for wound healing and negative for.
I'm sorry?
It's
Positive for pain, negative for edema, generally. Yes. Yes. It's a rule of thumb. Okay. Okay. So negative early inflammation, positive later to facilitate this epithelialization. I said that the negative polarity also brings in that phagocyte response, gets rid of all the debris in the tissue, and also neutrophils are released with each. Okay. So pulse duration and frequency, comfortable setting. So sensory, right? Sensory, 40 to 100 microseconds, a frequency of 60 to 125. Iontophoresis, we also talked about, you guys felt it. Did anybody have any reaction to it?
Kyle kind of did, I
Kyle
think.
did. Kyle got red.
Did anybody have any redness? Kyle?
Yes.
Yeah, did you have any burning or itching? Was it itchy?
It felt like a pinch almost.
Yeah. Okay, so remember the other day we tried iontophoresis, we also did that motor point stimulation, and that motor point stimulation was a DC current. And what do we know about DC currents? They're noxious, right? They're not fun, they're not comfortable, and when is the only time, Rodney, when is the only time we'd like to use DC currents? When are the only times we'd like to use DC currents?
So, edema, hyperesis.
Edema?
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 Yeah.
Edema is a reason to use DC current? There are three reasons we would use DC current.
Denervated muscles more than.
Denervated muscle,
Increases in
wound healing, and iontophoresis.
So no edema?
No, you could use a biphasic current for edema. You could use a Russian stim for edema.
Yeah, Kevin told us we use edema for that.
Kevin told you that?
Uh-oh.
Yeah,
but, like, why
would you use a really caustic way for edema?
Okay, but we don't want to use DC current unless we have to use it.
May I have your attention, please? Our college's coronavirus task force needs everyone's full cooperation and adherence to the CDC's COVID-19 guidelines when you are in the building. Everyone must wear a face mask at all times in public areas of the building. Everyone should observe social distancing, which is 6 feet apart. There should be no more than 2 people on an elevator at any one time. Everyone should wash their hands frequently, and if you feel ill, please stay home. Thank you for your cooperation.
Well, if you're still thinking, which I guess, again, I told you the jury's out, depending on what book you read, that high volt is considered a pulse galvanic, which is a pulse DC, yes, then I would say yes. So, and that's probably what he's operating on. But as a rule, let's just try to remember that the 3 reasons that, especially on the state board exam, that they would be asking why you would use a DC current would be for a denervated muscle, for iontophoresis, and for wound healing. Okay? So he's operating on the principle, yes, because you do have edema. You do have edema, so you have to have a polarity.
He said that because edema is negative, what he would do is like.
Because edema is negative, right, right. So that you would use a polarity, and that would be a high, but we don't call it high volt DC current anymore, we call it high volt pulse current. I just don't want you guys to get mixed up in the terminology, okay? Or like, what exactly is this modality? Is it a DC, is it a, they're still saying in some books that it is a DC current that they pulse, in some books they're saying it's not. So I just want to be consistent and let you know that a high volt, yes, you can use high volt, and because you have a polarity, would I call it a DC current? I would, but your book isn't, you know, so.
So, in regards to the EMO, you want to focus more on the AC current?
Well, you could use AC, you could use AC and you could use high volt pulse. Okay, you can use a high volt pulse current. Yeah.
I think the issue is like DC you wouldn't use for edema because it's so caustic.
DC you wouldn't use for an innervated muscle?
For like something where you have edema, you wouldn't want to necessarily use DC if you have other options.
Correct.
Because DC is so caustic.
Correct, correct. But when you pulse it and you do a high volt, which has that twin peak graphic representation, so it's on for such a short amount of time and it's so deep, that's a different story. If you take a regular DC current, you're not going to apply that DC current to something that's innervated. Yes?
So, what's it called? So a high voltage is pretty much like a DC current, right?
High volt is like what?
High volt is pretty much like DC. Like high volt and DC are pretty much like associated with each other, right?
Yes, because they call it high volt galvanic stimulation. And when you use the word galvanic, you're talking about a direct current.
Got it.
Yes.
Okay, thank you.
But yet, in different books, it's not called that. That's all I'm saying to you. So, but makes perfect sense to me that because it has a polarity and because it's galvanic current, that it is a DC current, but they're pulsing it and the current is on for such a short amount of time. So it's not your typical DC current that's on continuously or that you could pulse for a certain amount of seconds. Okay? And it's all done in the machine anyway. You have no control over changing it. All you can change with a high volt is negative and positive polarity. That's it. Okay. Dispersive electrode, we all know what a dispersive electrode is, right? So with wounds, you can use a dispersive electrode. A dispersive electrode 6 to 12 inches away from the body part being treated. In this picture, it had, or a picture here, it had on the foot. It's usually proximal to the wound. Okay. And we talked about the milliamp minute treatment, so either 40 or an 80 milliamp minute treatment for anaphylaxis. Okay. And remember I said, what would you probably be responsible for in the state board? Knowing the polarity of dexamethasone and hydrocortisone, because they're the most common ones used. So dexamethasone is a negative polarity, so where would you place it? Under what electrode, Monica? Under the positive or the negative electrode?
Negative.
Monica.
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 Which one?
Under what electrode would you place the medication if you were using dexamethasone?
The negative with cathode, because cathode is a negative electrode.
So you'd place it under the cathode. You're correct. Okay. Hydrocortisone, positive under. And what, Monica, would you do if you had an electrode and it was about that big, but the patient, even if when you administered 0.1 milliamps, it was too aggressive?
You have to get a bigger one.
There you go. You get a bigger one. All right, guys, I think you're doing okay. I think you're gonna pass. All right, we talked about the side effects, itching, burning, irritation. We talked about the side effects under a negative and under a positive electrode, right? Hydrochloric acid under the positive electrode and sodium hydroxide under the negative. And what do? In order to prevent that, they either buffer them or they deliver a low intensity current over a greater time. So if you're delivering 0.1 milliamps, you could deliver it over a 24-hour period. And what do you tell a person to do when they leave your clinic after iontophoresis?
Try to do
Nothing.
as much as
Rest,
possible so the
right?
medication stays in
Go to
place.
the gym and lift weights.
So,
I thought that's what you
but
said.
sometimes you just have to.
That's what he would do.
Restoring nutrient stuff for no one.
Because he's a non-compliant patient.
Do you think I'm non-compliant?
Yes, I
This
do.
guy ain't going to the gym.
Go to House
Okay,
Beans.
so conventional brief and text, acupuncture burst mode. Why do we modulate a current, Cindy? It's right up there.
Yes, so that we don't accommodate.
So we don't adapt to it and the nerves don't accommodate, right? So we could modulate. And when we modulate the currents in interferential, what two things can we modulate? The amplitude and the frequency. Absolutely. How do we modulate the frequency? By pushing what button?
Sweep.
Sweep. How do we modulate the amplitude?
Yeah.
Scan. All right. I think we're done. Got that exam Monday? No?
It's all right, thank you very much.
Electroplacements, conjugations, we already know. We know the neuromuscular indications. Okay. FES is here, so. Brush and stim. Okay. Brush and stim, we'll talk about them separately, just to go over everything. Brush and stim, brush and stim. Where's brush and stim? Brush and stim. All right, 2500 hertz, medium frequency current. It's interrupted. It's interrupted with this burst, 50 seconds, a burst rate of 50 seconds over a 10 milliseconds. Muscle re-education, we want a strong, tolerable current. We could use biphasic. It's stronger than biphasic because it has that burst. 150 or 150 to 200. Some books say 150 to 250. It doesn't matter to me. Nobody's going to ask you those specific numbers, but if you're going to see a definite difference between 250 and 350 as opposed to 150 and 250 or 100 and 200, 200 to 300. That's what I'm saying. So don't worry about the difference in the numbers. But you're going to use a larger pulse duration for larger muscles and a smaller pulse duration for smaller muscles. And we're going to use 35 to 50 hertz because greater than 50 hertz, will you still get tetany? Yes. But what will happen?
Fatigue.
You'll get more rapidly, you'll fatigue the muscle. Yes.
So for the question you asked in the beginning class with the 24-year-old femoral fracture, that one, so why would you, I mean, I know there's multiple answers, but could you start
It was on that.
with 10:30 and then see if it's comfortable?
Scanning,
and then-
amplitude, sweeping
No.
frequency.
No.
It's on the-
Okay,
it's
the
on
question is, can I start the patient with 10:30 and if it's comfortable during muscle education, move him to 10:10? No, because according to research and according to the evidence-based research, you don't allow enough time for depolarization and repolarization. And you also, when you do, you fatigue the muscle much more quickly. So you're actually fatiguing the muscle and not re-educating the muscle.
So when would it be a good option to use 10:10?
When you use 10:10, you could use it for something like spasm, muscle spasm, because you want to fatigue the muscle, or you could use it for edema.
So that same scenario you gave in the beginning, would either 10:50 or 10:30 be an acceptable answer for that?
Okay, so these parameters look good, right? So if I gave you a question that similar to what I asked this morning and said somebody had a fracture and then they had an extensor lag, which of these would you choose? High volt of intensity, motor intensity for 15 minutes. And that should be in your minds. You should completely rule that out because that duration is so short, that's not going to give you a motor response unless I turn it up so high. Biphasic current of 10 hertz and 250 microseconds. Biphasic current of 50 hertz and 250 microseconds. Or biphasic current of 80 hertz at 250 microseconds. Which one would you pick? You'd pick the third one, 50 hertz at 250 microseconds, right?
Okay.
All right, I'm gonna give you questions so that you guys can look at the questions, you can discuss them, you can work in a group and come up with an answer, yeah.
Is this applicable for the biphasic too?
What is what?
This parameter right here, is this applicable for
Yes.
biphasic?
Yes, yes. Yes.
I
Okay.
have a quick question.
So motor response, right?
Brian with an eye.
Brian has a question.
Yeah, right.
Yeah, so, regarding voltage, right?
Voltage?
I was reading through the PowerPoint last night, and you have two sections that say high voltage, like, low voltage is less than 100, and high
Less
voltage...
than 150 and high voltage is greater than 500.
Yeah, so, well, the one part, at the beginning of the PowerPoint, it says low voltage is 150 or less, or under 150, and then high voltage is above
Yes.
150, but then going forward a few slides, you have low voltage 100, and then high voltage 100.
Oh, really? Where?
So, slide 20.
Where am I?
I don't know if that's just
We're around
talking in
80.
regards to stim units, but
Where would it be? How far
slide
am I
20.
off? Do I have to go back or how do I go forward?
Go back.
Go back.
Like way
Yeah,
back.
Slide 20, a lot.
Yeah, keep
You
going.
also set to the water.
Where?
Keep going.
It's under stimulation unit.
Right there?
No,
No, way back.
Like all the way up.
yeah, keep going.
Here?
No. Way back.
Keep going?
Keep going.
Yeah.
You can escape it.
Escape.
Oh, it's almost, you're almost there.
Oh, keep going, almost there.
Just a few more.
Right there.
So you have that one, and then if you go to the very beginning, where is it? I think.
Well, 100, 150 doesn't really matter. It's a tens unit, that's a battery, that's low voltage. High voltage, anything greater, it should say greater, it should be greater than one.
Yeah, then on slide 10.
Slide
you go
10?
back 10 more slides, then it says low voltage requires a force of 150 or less, high voltage 150 or greater.
Here?
Yeah, right there.
High voltage equipment requires a force of 150 or greater, right, and less than 150 is low volt. Yes, that's basically what it is. 150 or lower is low volt, 150, 150, oh no.
So my question is, if we get asked a question like that
No,
on the
no, no,
test-
no, you won't.
Alright.
You won't get asked a question like that. That low voltage is 150 volts and anything higher than that would be considered high volts.
So we should just remember 150.
Yeah,
Alright, so let's change those.
okay. But that's, I know why you're confused, because that's in a portable unit, so it's different in portable units. But you won't get asked that anyway. Alright, so for muscle re-education, initially, you have to do 10 on, 50 off, right? And then as the patient gets used to it, generally what you'll see is they put it on 10 on, 30 off anyway. 10 on, 10 off. What does it say, 1 on? It should say 10 on, guys. Progress to treatment time of 10 on, 30 off, not 1 on. Okay? 10 on, 30 off. For edema and muscle spasm, the ratio is 1 to 1. Okay? Because it'll cause muscle fatigue. So 1 to 1. So in your machines, if you have 10 on, 10 off, and you can't change them, use that. If you could change it to 5 on, 5 off, you could do that too. Your books say anywhere from 2 pulses per second to 5 pulses per second, but you could choose the setting that has 10 on, 10 off. Okay? Yeah.
For muscle re-education, you're going to need a ramp cycle or a ramp of 2 to 3 seconds. For edema and muscle spasm, would you also want
No.
a ramp?
No. If I want to get rid of edema, if I want to get rid of muscle spasm, I want to bombard it. I don't really want to let's be nice and gradually increase it. I want to just bombard it. Yeah. Okay? And for muscle strength, generally, you won't do this, but they've done this with evidence-based practice, they've done this with research, they do this with athletes. So in order to really make sure that you're doing strengthening exercises for this patient, you take 50% of the maximal voluntary isometric contraction. So we determine on a machine what the maximal voluntary isometric contraction is. You don't determine it by just touching a patient. You have to put them on some kind of, you have to look at the peak torque, you have to look at the torque over time, and you're going to look at the maximum voluntary isometric contraction, and then you're going to begin, if somebody's really injured and really weak, with 10% of the maximal contraction, and then work your way up. Okay, that's what we really do out there when you're working with athletes and you have the ability to have all these other machines and these biodexes and these isokinetic machines where a computer determines all this. Yes?
So sorry, what's it called again? The maximum voltage isometric?
Maximal voluntary isometric contraction. Okay? Maximal voluntary isometric contraction. So if you're going to be doing some research, this is probably what you're going to be looking at. Okay, so you want at least 10 to 20 good contractions for muscle re-education. You want to put the electrode on the belly of the muscle and not on the tendon because it's not contractile. And you want to have the patient participate. And you want to ask the patient, how do they feel? Okay, so if you see any signs of fatiguing, maybe it's too aggressive for the patient. Maybe the current you chose is too aggressive for the patient, or maybe the patient is just too weak. Yes?
So this is another example where, like, previously you said 10 contractions is what you're looking for.
Yeah.
If you do more, it's fatigue. If you do less, it's not enough.
Right.
Should we say 10 or 10 to 20?
It doesn't matter. It doesn't matter. Again, that question will never be asked because it depends what book. It depends on the current of the machine. They're all a little bit different. I mean, even though the frequency is set, you have to go according to what the manufacturer says. And if the manufacturer says you want 10, your book says 10 good contractions. If you look at some of these manuals, they say 10 to 20. That's why they set a specific time. So if their time is 10 minutes, then don't try to increase it to 15 or 20. Because sometimes, years ago, what we did is we would have to set a time. So we would know that we want 10 good contractions because we really didn't know what was going on inside the machine. Okay. So we just want to also go by what the patient's reporting us. If we're seeing that the patient, after 2 or 3 contractions, the patient can't volitionally activate the limb, then we need to make sure that we change either the type of stim we're using or change the time, or turn it off before the designated time on the machine, because we don't want fatigue. All right, acute pain, you can use interferential, pre-modulated. I sent you something today too about the things that you could use for, as I think you're getting used to, you could use more than one thing for, more than one type of stimulation for more than one thing, right? If you have edema, you don't have to use just a high volt machine. You could use a biphasic. You could use all these different frequency currents. All right? So as long as you have the appropriate rationale, and I think we were talking it with you guys last time, right? As long as you explain to me while you're doing it, fine. Fine. If you said to me, I'm using ultrasound to heat up this muscle, what would I say?
What are the parameters?
What would I say?
Well, if there's a demon,
Does a muscle have a high absorption coefficient?
No.
No. So would I use ultrasound to heat up a muscle? No. So these are the things that I would say to you. If you said to me, like you said to me, Kyle, the other day, that you wanted to use a high frequency and a low duration for pain, right? And that you wanted to use a biphasic current or pre-modulated current because you thought it might be more comfortable, or whatever you said to me. You're absolutely right. Can you use a biphasic? Can you use an interferential? Sure. You could use those currents too. As long as you know what you're doing and why you're doing it, it's fine. So that's why I said, if you want if you want acute pain, no matter what machine you pick, no matter what, you always want a high frequency, and the high frequency In some books say 80 to 150. In some books say it's 80 to 120. Don't worry about those numbers. However, if you see on the state board 80 to 120 as opposed to 50 to 90, what are you going to choose? 80 to 120. Okay, it's a higher frequency and a low pulse duration. If the duration says 40 to 60 microseconds as opposed to 25 to 50 microseconds, it doesn't matter. That number, don't memorize the numbers. All right? Understand the concept. All right, duration, shorter duration, longer duration, shorter frequency, higher frequency. Yes, Rodney.
So,
Can I get through this today?
so assuming that, like, if there's a multiple choice in regards to frequency, just pick the lowest number.
Yes. Yes. Or, although, if it says, are you going to pick, what are you choosing for chronic pain? A frequency of 0 to 10? Or a frequency of 40 to 50? What would you choose?
0 to 10.
0 to 10. Yes. I'm sorry, I didn't mean to offend anybody, that's just the
You gotta watch it these
Catholic,
days.
Catholic schoolgirl coming out.
Never mind.
Did I tell you I was in the convent?
No way.
Could you imagine?
No.
I was. Go ahead.
Oh, I was gonna ask you some bullshit, never mind.
You don't want to ask me?
What's your favorite color?
Blue. Okay. What, you thought it was black?
No. I was just gonna ask you
Oh.
some bullshit.
All right, so you could use a microcurrent. We're not using microcurrent. Microcurrents are subsensory, but if you wanted to use a microcurrent, and this probably is not on the state board. I don't think microcurrent is. That's why we really haven't used it. The intensity and the amperage are different from, it's 0.3 hertz. That's really, really low, and it's subsensory. Microcurrents are subsensory.
This is an
So a subacute or chronic, you could use all the same things. Biphasic, interferential, free modulated, high volt, microcurrent, ultrasound with biphasic, low frequency, sensory, long pulse duration.
This
Yes.
is a real question. So clinically, I've seen micro used for edema as well. Does that hold water?
Edema for, what do you see?
Microcurrent for edema?
You know, and we really haven't talked about this. Yes, microcurrent is used for edema as well as pain. I think microcurrent works very well. However, people don't like it because they don't feel
Yeah, you don't
anything.
feel anything.
It's subsensory, so you feel nothing. So a patient will usually say, you know, I don't think it's working. So for a patient like that, you would want to use something where they feel, because in their mind, they're not getting better. You know, and you have to think about, well, you may say to them, let's try it, you know, and if they come back next time and say, you know, I didn't feel anything, didn't make me feel better at all, then you would use something where they feel. Otherwise, you know, if you get them to be a believer, because they do work. But it depends on the patient. All right, so general rule, what did I say? General rule, positive for pain, negative for edema. All right, it can also be used for spasticity. So if somebody has spasticity and they have an agonist or an antagonist, so we're going to use alternate, right? We could use an alternating current. If we could set the currents differently or separately, we could set one side to fatigue and the other side to stim a muscle. All right, for the agonist, use a frequency of 100 hertz, 10 on, 10 off, with a visible contraction until you fatigue it. And antagonist, you want a motor response, so 10 on, 10 and 30 off. So if we have the ability to do this in the machine, we could use this for somebody who has spasticity. Okay. Interferential current. Interferential current uses two generators. Generally, the generators. How many electrodes do you need for interferential current? 4. Because you have two medium frequency generators. Some books say one generator is 4,000 hertz. The other book says it's 5,000. It doesn't matter. There's two different generators. One generator is, let's say it was 4,000. One generator is 4,000, the other is 4,100. So 4,100. So what happens is when you put these pads on people, you get a beat frequency of 100 hertz. The other thing that's important about interferential is it's much more comfortable than any other current, because when you have a greater current frequency, not something you set, but the current itself. So this current is 4100 hertz or 4000 hertz. When you have a greater current frequency, you have less tissue impedance. Okay? You have less tissue impedance, and the current can travel through the skin, which is the tissue impedance would be the skin, and it can flow deeper into the tissues. Okay, so there's an inverse proportion between the current frequency and the resistance of the skin. All right, and generally, and this was found by research, at a frequency of 4000 hertz, which are these interferential currents, the skin resistance is 80 times lower than a current that has a frequency of 50 hertz. Okay? You don't have to remember these numbers. It's just that I'm giving you some information to support the fact that this current is very comfortable. All right? So why is interferential current comfortable? Because it has a high frequency, and the greater the frequency of the current, the less skin resistance there is. There are less tissue impedance. So the easier the current flow, and the deeper.
That Ohm's law? That would be talking about Ohm's law?
No.
I'm off.
Well, yeah, sort of, because I equals V over R, so the resistance, but it applies, it applies in some way. I mean, it's applicable. It's not what Ohm's law states, but, yeah. Okay? So when is current density greatest? At the electrode tissue interface, and what else? Under the smaller electrode. Okay? So interferential is very good. So we have these 4 electrodes that we have to crisscross, because we were looking for target tissue, and we could change where the target is by pushing on those little, did everybody feel the little units, the little Dynatron units? You could actually move where this intersection, where this cloverleaf pattern takes place. So you could target specifically where you want. Okay? So it's a pulse biphasic waveform. You can't set the pulse duration in these currents, in these machines. They're already set for you, which is good. But if I ask you, you would say pulse duration is probably going to be high enough to get a contraction if that's what I want, or low enough to get to sensory response. So acute, the 50 to 80 microseconds, your frequency, if you choose an 80 to 50 pulse per second, it's going to turn on a duration of 50 to 80 microseconds. Do you think that's good? Do you think it's the same thing that we've been saying all along? Yes. High frequency, low pulse duration. Low frequency of 2 to 10 pulses per second. What's the duration? 200 to 300 microseconds. Okay? So is it any different than we've been talking about? No. All right. So when this current crosses or flows into the tissues, if we have less skin resistance, then do you think we've stimulated nociceptor release? No. No. So it's really comfortable. Okay. So we talked about where the current goes into. Sometimes it intersects. Sometimes it works. Sometimes it joins. It intersects, and sometimes it doesn't. So we have this cloverleaf pattern, which I'll show you in a minute, from these 2 generators that you're delivering through 2 separate channels. And that whole frequency is known as the carrier frequency, and the intersection of these currents is known as the beat frequency. Okay? So it's more comfortable. You don't have to worry about anything else there, just remember what it says. So here we have 5,000 hertz, 550, 100 hertz, and this is what you have, a cloverleaf pattern. So it says here, intersecting medium frequency alternating currents, an alternating current with a frequency of 5,000 hertz, and even though your book says 4,000, with an alternating current frequency of 5,100 hertz, produces an interferential current beat with the resulting 100 hertz. Okay? All right. That's that cloverleaf pattern. Okay? Here's 4,000 hertz, 3,900 hertz. It doesn't matter what these numbers say. We just threw off by 100, whether it's 4,000, whether it's 5,000, whether it's 3,900. It's a high frequency current. What does this high frequency current do? Decreases skin resistance, okay, at the electrode tissue interface. So it's more comfortable. All right. So again, isn't this getting monotonous?
Yeah.
Yes. So should we skip it?
No.
Nah.
Oh, there was another fact that I wanted. I put a delta here. When you have microseconds of between 50 and 80 microseconds, if you choose something between 50 and 80 microseconds, it's thought to depolarize sensory nerves. Okay, so a pulse duration of 50 to 80 microseconds. The rationale for choosing that is because 80 to 50 microseconds, when you choose that depolarized A delta nerve, sensory nerves, a frequency, or I'm sorry, I keep saying frequency, a pulse duration of 200 to 300 will depolarize A beta,
Sorry, what was the number?
200 to 300. Okay? And now, let's see. So this is pretty. So we're going to do quadrupolar. We're going to use 4 electrodes, channel A, channel B. So we always have to cross the electrodes. Okay? Strong sensory level for acute pain, a motor response for chronic pain. Pre-modulated, everything I said about pre-modulated current is not the same as interferential. It doesn't have the same, it doesn't feel as comfortable as interferential because the frequency is not as high. Okay, so, but these generators are in the machine itself. Okay, they're both in the machine for both interferential and pre-modulated, but for interferential you have to cross the electrode because you use 2 channels. For pre-modulated you use 1 channel. It's all done within the machine itself. Okay, so pre-modulated is a current that you're using for the same things that you're using for interferential. It's just not as comfortable. Okay, so you can use it for pain and you can use it for edema. Alright. And again, you can have a duty cycle if you want. If you don't want to have a duty cycle, you don't have to. You wouldn't use duty cycle for pain or for edema. Or you can use a duty cycle of 10 on, 10 off, or 5 on or 5 off for edema, but not for pain. Okay. Contraindications and precautions for any of this stimulation. Areas of sensitivity, right? Carotid sinus. Why not over the carotid sinus? Carotid artery. Why? Because we have baroreceptors and chemoreceptors in the carotid artery, as well as the aortic arch, which change blood pressure, right? We could actually, if you put pressure on this area, you can actually cause a drop in blood pressure, and the person can faint. So do not stay away from these areas. Stay away from the esophagus, the larynx, the pharynx, the eyes, the temporal region. Anything with a pulse, right? We're not going to do. The upper thorax around the heart. So we're not, especially pacemakers and things like that. Somebody with a lot of fat, somebody who's epileptic, If they have any kind of a electronical monitoring device, stay away from it. Cardiac disabilities, pacemakers, pregnancies, menstruation, cancerous lesions, sites of infections, and exposed metal implants. Okay, so contraindications as well as precautions. And then we have this low-intensity direct current, which is microcurrent, and it's thought to stimulate healing, tissue healing, ATP synthesis, and increase protein synthesis. And the reason why people don't like it is because they don't feel it. So they say, well, if it's not working, then if I don't feel it, it's not working. So we're really probably not going to try it, but those of you who want to can. And you could be doing any of these things with either probes or, and I'll share with you that I had worked with a gentleman with microcurrent for his mouse, because he only had about 5 millimeters of vertical opening. And he was a dystrophy patient, so I had to get his mouth open. So I would put the probe inside with a long Q-tip attached to the probe itself and work on some of the masseter muscles to try to get them to relax to open. So that was probably the only time that I ever really used a probe. But there are probes, and you may see probes used in clinic. Okay, they're still delivering the same amount of current, it's just going to be a probe and not an electrode. All right, and finally biofeedback. Professor Mealy will show you biofeedback today. It's going to measure the amplitude of the motor unit action potentials in millivolts. So motor unit action potentials in millivolts, and there's a visual and audio feedback, and it will help a patient understand whether they're in a constant state of a contraction or whether they're not using their muscles at all, because it'll give them feedback. So if you place electrodes on somebody and their muscles are really firing all the time, like somebody who has a lot of tension in their upper traps, you can set the machine and say, you could set it to have a visual output, but more so an audio output, because if you have a visual output, then they have to keep staring at the machine. So if you have audio output and it makes noise like beep, 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 you could say to them, I want you to stop the noise. So how do they do that? They have to learn to relax the muscle, because as soon as they start doing this, the machine goes beep, and then as they relax, it might go beep, 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 and then they'll start to relax the muscle, because your brain has memory. And we talk about this all the time. When you do a massage with somebody, or you do something with somebody, or even a contract relax with somebody, or even stretch your hamstring, what happens if they don't do anything to feed into this new muscle length, or they walk out of the clinic in the case of like an upper trap and they just go right back here. So you can tell somebody all you want, relax your muscle, relax your muscle, relax your muscle, but not until they feel what it's like to relax do they realize, okay, this is the way it's supposed to feel. So biofeedback is really good. You don't see it used that much because it takes time. And like therapists like to, in the 20-minute treatment, throw a stim unit on somebody and then get them out. And then the patient comes back and says, oh, it's so much pain, and you put the stim unit, oh, it feels so much better. But really, your brain needs to have this new motor pattern and understand that I'm not going to sit here like this. This should not fire. This should not be normal for me. I should relax. Okay, so we're going to do a biofeedback. It's also good for muscle re-education. So if you have somebody who has a lateral tracking problem of the patella, and maybe the lateral tracking problem is due to an imbalance between the VMO and the VL, or even the IT and the TFL, in order to get the VMO to fire, we need to do some kind of either a stimulation, some kind of a tapping to get that muscle to work, but more so, throw a biofeedback machine on them and say, okay, I want you to now make this machine make noise. Because you could just do this and not use a VMO. I mean, a lot of people do that and the VMO's not on at all. so you can get them to train or to retrain. Half of you, I venture to say, and especially Joe, has no lower travel. So if we put the biofeedback on him and said, okay, I want you to lift your arm and I want you to make this machine make noise, then, only then would you say, oh, okay, I need to do that action in order for it to turn on that trap. But otherwise, you're not going to know, right? So that's why we use biofeedback. Okay. How much time? We have 7 minutes, 8 minutes? Yes?
Probably like 6.5.
6.5? Do we have enough time? All right, so we're also going to talk about, should we talk about compression devices? Or let me just say this. We'll talk about compression devices enough to say that a compression device, this external device will help with fluid, right? Because we talked about the fact that we have these one-way valves and the one-way valves push fluid up to the heart. So if we have, what happens when we have compression, so normally the fluid equilibrium is associated with both hydrostatic pressure, I sent you this today, hydrostatic pressure as well as osmotic pressure. So there's a balance inside and outside of the blood cells. The hydrostatic pressure pushes fluid out of the blood vessels, and the osmotic pressure helps pull it back inside. So we get a balance. So if we have any kind of an imbalance at all, will result in edema into the interstitial spaces. The edema in the interstitial spaces is then picked up by the lymphatic system. The lymphatic system pumps it through into the vena cava and through eventually into the heart and through the circulation, right? Yes?
Yeah.
Okay. So we're going to use an external compression device, or these units are called Job's compression devices, which will help decrease this fluid. So it will decrease edema. Is edema good to have?
No.
It depends. It depends.
It depends.
Most
So edema is kind of a wake-up call saying there's a problem, right? So we have a normal inflammatory response maybe, and we have some edema, and then we have our natural, our histaminic response, et cetera, to get rid of it.
Ankle, you better have some.
But if we have edema for a long period of time, we need to get rid of it, especially lymphedema. All right, lymphedema carries with it its high concentration of protein, so you can have a greater bacterial infection with lymphedema. So, you know what, by the time I get it up, we have 5 minutes.
Yeah, according to Joe, we only have
Probably 4.5 according to Joe.
All right, we'll start lab a little earlier. And maybe we'll use the machine and you could see what the machine is, and then we'll talk about, because it's a very short presentation. All right, so you can read about, yeah, let me see if I can get you some questions too, to do in lab.
Should we take notes on the compression,
Take notes on what?
compression PowerPoint?